Hello, Dr. Bergen. I'm going to be doing the Unit 4 case connection video presentation, and I'll be covering case 1 and case 2. So, for case 1, a newborn girl appeared normal at birth. In 24 hours, she became lethargic, hypothermic, and apneic. Which diagnostic would be the best to distinguish between a urea cycle disorder and a beta oxidation disorder? So, as far as blood glucose goes, that is going to be good at distinguishing a beta oxidation deficit or disorder. The reason why that would be occurring is because with deficit in beta oxidation, we're most likely going to have hypoglycemia. Beta oxidation is utilized in the fasted state so that we are able to provide TCA and gluconeogenic intermediates to replenish our blood glucose levels and ATP energy levels. However, if there's an issue with the enzymes or substrates of beta oxidation, such as carnitine as a substrate, or carnitine palmitoyl transferase 1 or 2, or even mitochondrial acyl-CoA dehydrogenase. If there's a deficit of any of those, we won't be able to undergo fatty acid beta oxidation, and we won't be able to produce those intermediates for gluconeogenesis or for ATP production through TCA cycle. Urinary acids. That's going to be more so, actually that applies to either. The reason why is because when there's a deficit with beta oxidation, in particular, if there's a deficit with mitochondrial acyl-CoA dehydrogenase, you'll end up producing carboxylic acids in your urine, and that's an indication of that particular enzyme having a deficit for beta oxidation. Also, if there's a deficit with your ability to use the urea cycle, you'll end up producing urine orotate in your urine, and that's because the deficit with the urea cycle would involve ornithine carbamoyl transferase. And when there's a deficit with ornithine carbamoyl transferase, we are not able to transfer our carbamyl phosphate and ornithine into sutralene. Therefore, the excess carbamyl phosphate undergoes a different pathway, and that pathway of pyrimidine synthesis ends up producing orotic acid, and we end up having orotic aciduria present in our urine. So that's how urine acids can be good at actually distinguishing both beta oxidation deficits or urea cycle deficits. With serum fatty acids, that's going to do a good job at distinguishing a disorder with beta oxidation, usually involving substrates or an enzyme involved with beta oxidation. And what's most notable, or what stands out the most to me as far as where the deficit would be, it would have to be a deficit with either having carnitine absent in the individual, or issues with the CPT1 or CPT2 enzymes, because if there was an issue with carnitine or its correlating enzymes, we would not be able to get fatty acids into the mitochondria, and there would be excess lipids or excess fatty acids in the serum. But for urea cycle, the fatty acids in the serum wouldn't be a good indicator of a deficit there. For plasma glutamine, that's actually going to be a good indicator for a disorder involving the urea cycle. If there's an issue in any of the pathways of the urea cycle, we're most likely going to end up accumulating ammonia in our bloodstream, and the peripheral tissues won't like that. So with our peripheral tissues, they utilize glutamate, and they end up converting the glutamate into glutamine by the enzyme glutamine synthetase, and that's a way for the peripheral tissues to fix ammonia to the glutamine and move it out of their tissues and send it to the liver to undergo the urea cycle and get rid of that excess ammonia. So we will end up seeing elevated glutamine levels because our peripheral tissues are going to be really undergoing that process to kind of get rid of the excess ammonia. Unfortunately, it'll be to no benefit, but still we'll see elevated glutamine levels in that regard. The next portion of the question says a full blood workup was ordered for this female, and the data is presented below. Initial blood ammonia level was elevated to 314 and rapidly rose to 600. Urine orotic acid level was markedly elevated at 473, and the plasma citrulline level was normal at 10. In this patient where orotic acid levels are elevated, list one urea cycle enzyme that most likely is deficient and one urea cycle enzyme that is least likely impaired. The enzyme that's most likely to be deficient in the urea cycle is going to be the ornithine carbamyl transferase enzyme. The reason why I believe it would be that is because we're seeing orotic aciduria occur, and we're seeing lower than normal levels of citrulline. The citrulline level is listed at 10, and the question has a normal citrulline listed at 12 to 55. Therefore, if we're unable to convert our carbamyl phosphate and our ornithine into citrulline, that excess carbamyl phosphate will undergo the pathway of pyrimidine synthesis, which ends up producing orotic acid, and the individual will end up having orotic aciduria present in their urine. The urea cycle enzyme that is least likely deficient is going to be the carbamyl phosphate synthetase. And the reason why the carbamyl phosphate synthetase 1 is least likely deficient is because we wouldn't have that orotic aciduria from excess carbamyl phosphate accumulation if the enzyme responsible for producing carbamyl phosphate was not working. So I do not believe there's an issue with carbamyl phosphate synthetase 1, which utilizes CO2 and nitrogen and it ends up converting them into carbamyl phosphate. For case 2, it lists a 4-day-old infant, patient A, is being followed in your clinic. Her birth weight was 5.9 pounds, and the pregnancy and birth were normal. Results from newborn screening would demonstrate a phenylalanine level of 6.6. The normal range is 1 to 2. A presumptive diagnosis of phenylketonuria was made, and additional samples were obtained for further analysis. The parents deny a family history of phenylketonuria. As a consequence of this presentation, which amino acid may become essential? The amino acid that's definitely going to become essential if it's phenylketonuria is going to be tyrosine. Phenylalanine is directly metabolized into tyrosine using phenylalanine hydroxylase, and if there's a deficit with phenylalanine hydroxylase, or if there's a deficit in the cofactor tetrahydrobiopterin, BH4, we could end up seeing elevated phenylalanine levels as well as decreased tyrosine production. Phenylalanine dietary restriction therapy was initiated 14 days ago, and with a good response of plasma phenylalanine levels dropping to the within normal limit range. what are the potential causes of the presentation of phenylketonuria? As I previously just mentioned, the potential causes of phenylketonuria are in regards to there being a deficit in the enzyme phenylalanine hydroxylase or the cofactor for the enzyme tetrahydrobiopterin. Another infant, patient B, is also being evaluated for suspected phenylketonuria. BH4 loading tests are performed on both patients, and the results are presented below. Tablets of synthetic cofactor are dissolved in 20 mL of water and administered to the patients at least 30 minutes before a meal. Blood was drawn before, at 4 hours, and 8 hours after the BH4 loading. Phenylalanine levels are determined. The question asks, how would you summarize the results of this test for patient A and for patient B? So we'll take a look at it together. So it looks like with patient A, after they got their BH4 cofactor, to see if that would help out in any way, shape, or form, unfortunately, it looks like their phenylalanine levels actually continued to elevate. With patient B, after they received their BH4 cofactor, it looks like their phenylalanine levels started to decrease at 4 hours and go much lower at 8 hours after administration. My analysis of their response of patient A versus the response of patient B indicate that patient A's issue is primarily with the enzyme phenylalanine hydroxylase. I believe they're deficient in the enzyme because when we give the cofactor of the enzyme to patient B, we start seeing the enzyme work and the infant's phenylalanine levels decrease for patient B. But for patient A, despite us giving the cofactor to help out with that enzyme activity, we still see elevated levels of phenylalanine. So to reiterate, patient A must have an issue with the actual enzyme, phenylalanine hydroxylase, and patient B must have a deficit in the cofactor, BH4. All right, well, that sums up my case connection video, and I appreciate your time. Have a good day.